This conference will now be recorded.
So welcome everybody. Thanks for being here. Excited about this. I mean, if you've been doing PARB or reviewing cases for any length of time, you know that the most challenging kids are the ones, or the cases are the ones where the kids have some sort of mental health or some developmentally disabled condition, low IQ or low mental health functioning that just makes them so hard to play, so hard to be stable. And I think this is an area where both mental health and this developmental disability, we could all, enjoy the opportunity to know what the resources are and just know more about the subject in general. There is in Oklahoma County, and Leslie is part of that. And Derek, I think are you a part of that? You are. Okay, I couldn't remember. That is focused just on kids with, it's just a mental health PARB board to look at kids that are in long-term placement, to focus on medication management. That's kind of an issue that happens a lot, in and out of hospitals, trying to reduce length of stay. So real excited about that mental health PARB board, and certainly other counties that don't have specialty boards like Oklahoma County and Tulsa County do. Still, if you can increase your knowledge of mental health and developmental disabilities, I think that'll help. So with that, I'm going to hand it over to Derek Duncan with the Developmental Disabilities Services. I used to call it DDSD. I have to take out one of the D's now. Developmental Disabilities Services. And I'm going to share my screen too. So take it away, Derek.
Right. Well, I'm Derek Duncan. I'm with Developmental Disability Services at State Office. I work intake, and I also work a program with the J.D. McCarty Center called the CARE program. DDS collaborates with child welfare for placement of custody kids and support of custody kids that have intellectual disability. And Keith, you can just go to the next slide. In order to qualify for our services, a child must be diagnosed with an intellectual disability and have an IQ under 75. In order for them to get on our program, we do require an app be submitted. And for us, the app comes through child welfare typically. It's required that we have the app, social security card, a birth certificate, and then a psych eval that has an adaptive functioning score and a diagnosis of intellectual disability. When we get the application, we review it, and it's assigned to myself or one of the other intake workers out of the areas, and we would complete a needs assessment and make recommendations at that time. Based on those recommendations, it can be that the kid's just added to the wait list, meaning that their needs are currently being met in whatever environment they're in. There's a lot of services that come through child welfare and EPSDT, and Developmental Disability Services has to be the funder of last resort. So if we can find a way to meet the needs through other services, we're obligated to do that first. We do provide services in traditional foster care placements. We have a couple residential options available, but these are typically reserved for custody kids only, and they are specialized foster care, agency companion, and level D group homes. Specialized foster care looks like a traditional foster care placement. The provider has some specialized training with children or individuals with intellectual disability, and they can have up to three children in the home, or provide care to up to 3 individuals in the home. Agency companion is considered to be a more like a higher level care, and it's typically a one-on-one, one caregiver to one client. And then the level D group home is an 8-bed, they're 8-bed facilities, and they're typically reserved with kids that have dual diagnosis. So they'll have intellectual disability accompanied by some type of mental health issue, or they can just present with very significant support needs that can't be handled in a more community placement. You can go to the next one, Keith. Whenever we do the needs assessment, we make recommendations. They go to grant staffing. Now, grant staffing consists of state office personnel from DDS and child welfare. In those meetings, we cover kids that are aging out of child welfare services, kids that are inpatient, maybe at SHIELD, essentially kids that might be too unstable for placement at this time. Currently, we have 71 children on our grant staffing list. If we deem that the child is appropriate for community placement, then they would go to the child placement review, and that's essentially a monthly search. It's a monthly meeting that we do searches and try to identify appropriate placements for the kids. Typically, when we do this, we review the provider and the children, and we try to make matches that are very intentional, not just to fill a bed. The services that we provide, past residential services. So in a traditional foster placement, we could provide habilitation training services or family training are the two services that we can provide in those. Habilitation training specialist is essentially a direct care staff that works with the client, and it's based on identified training needs for the individual. The services can't be authorized overnight, and they're not in to replace supervision of parents and things of that nature. They're there to work on teaching the kid to be more independent in daily living skills, community integration, things of that nature. In addition to DDS, I also work with the CARE program. And the CARE program is a collaboration with J.D. McCarty, Developmental Disabilities Services, and Child Welfare. We help families. Let me pull that up quick. CARE stands for Connecting with Families, Assessing Resources, and responding to needs and enhancing lives. We do outreach to assist families who have children with developmental disability services. Currently, I'm reaching out to families that are on the DDS wait list. There's a child welfare rep that reaches out to custody children, the providers for custody children with intellectual disability. And then we also take referrals from other resources. So if you were to come across a family that was in need or that was having some problems, they could be referred to us as well. In that, we basically meet with the family, we do an evaluation through an initial assessment. We help the family to build bridges to support services. We connect them with behavioral support services, medication assessments. We really do a little bit of anything that we can to kind of help the family get stable and to kind of find their happy place. Biggest goal is to link families with community resources and services and trainings based on the needs of their child to kind of help potentially prevent DHS involvement down the road. That's my high flyover, Keith.
All right, well, I've got it.
I sent you that map if you want to put that up.
Yes.
And that's got contact information. You can contact anybody on that slide. We do have it divided in areas, but it doesn't matter. If you contact one of us, we'll get it to the right person. Did anybody have any questions?
I had a question, Keith. For that number of 71 in the staffing, does that mean that there are 71 kids at any time that are using these services, or are those like a new 71 that are being staffed this month, but then there are still an additional group?
Those are the 71 that we're currently staffing. So there's 71 children that we've got identified that are either aging out or are at some type of inpatient stay or shelter or somewhere that don't have an identified permanent placement.
And then I was also curious about how Liberty and the Laura Dester Center are going. Does that fall under DDS, or is that not one of the providers that you're talking about?
Shield is actually a partnership. The way I understand Shield is it's a partnership with Child Welfare and DDS. I believe that DDS actually holds the contract, but then the financial piece is split between DDS and Child Welfare. Typically, the gatekeeping or the admissions piece of that is controlled by Child Welfare. And so sadly, we as a state don't have a lot of services for children that are not in custody, or at least residential placements we don't have.
So if as a PARB board, you come across a case that, it's clearly some developmental disabilities, low IQ, that sort of thing. I mean, the DHS is going to automatically make a referral to you guys, right?
They're supposed to, but sometimes you do find kids that are out there that they've got IEPs and they've had things and there hasn't been a DBS application completed. I would recommend that if y'all come across a case in your reviews that you think might qualify, that you make that one of your recommendations would be to see about an application for DDS.
That's good to know. And that will be part of their service plan, I would imagine, wouldn't it?
Say that again.
Well, would that be part of those services be listed in the ISP? Not necessarily would it, but it would be with the parents. How would we know?
How would you know? Well, if you've got a kiddo that's on in special education program, that can be an indicator. Typically the psych eval, I don't know what all information you normally get during the reviews. We tend to get a lot of the psych evals whenever we're doing ours.
Well, we look at the case file. Of course, hopefully we're hearing from a child welfare worker or their supervisor, but we typically are looking at the case file, which is going to have the individual service plan on it and stuff like that. So I'm wondering if that any DDS services would be listed. Probably not. Kim, I hate to put you on the spot while you're driving, but do you know if how much that would be identified?
Hey, Keith.
Yeah.
Can you hear me okay?
Yes.
Okay, just go ahead and repeat the question for me. I want to make sure I understood it. How much?
Well,
Yeah,
when we're if we are trying to assess, we figured out that they've got kid with some developmental disabilities, and maybe, you know, a low IQ is reported, or you can just tell from the case notes or whatever. How can we tell that they've been referred? You know, what kind of services would be listed in the ISP or somewhere else to let us know that they're connected?
Right. Okay. That's got a couple answers. Definitely the first thing I think that the group volunteer is going to want to look at specifically is the child's treatment plan. I don't know that you should see a connection between whatever, particularly the first step in identifying DDSD is the psych eval. They almost always are going to want IQ and potential diagnosis to help determine whether or not DDSD is going to be appropriate. So the first step would be is ensuring and talking to the worker about whether or not we have a psychological evaluation done on the kiddo, where we might be questioning if those services are appropriate. As a reminder, PARB is entitled to those documents, so without court order. So you can request either the results, or you can actually request a copy of that from the worker to review, or to at least ensure it's been ordered. If that's been done and the child qualifies, or if you have questions if the child qualifies, then you could absolutely look to the child's treatment plan to see if that referral has already been made. I still think one of the areas where we could have improvement statewide with DHS is in writing children's treatment plans. They tend to be a little generic. So if you don't see it on the treatment plan, don't assume it hasn't been done. It's important to go ahead and ask, because sometimes DDSD services aren't something that's identified initially. It may take beyond the initial entry of the treatment plan before they are identified. So I would start by reviewing those and then asking the DHS worker. And then if those referrals haven't been made, I agree. It's absolutely, with Derek, it's absolutely a referral that PARB should consider making.
Right. Cool, thanks.
And
that.
If y'all are wondering if there is a DDS application on somebody, I can look that up.
Okay, that's good to know. Appreciate it. And just FYI, I will email out all these handouts to everybody that's on this call. So,
Keith, I'll send you the link for CARE as well, because CARE is also another resource that, you know, it's outside the traditional kind of containment that we have with kids got to be in custody for child welfare to help, or they've got to be DDS for DDS to help. CARE's kind of opened us up, and so we're able to help families that fall outside of those.
Okay, that's good to know too. All right, anybody else have any questions or thoughts? Well, it's nice to know. I appreciate you sharing this, Derek, and put yourself out there for us, because it is, as I'm sure you know, it's tough. I mean, kids with you know, some developmental disabilities are sometimes hard to parent and are often get abused, and it's also often hard to find foster placements and everything else. So it's nice to know these resources are out there.
No problem.
All right, I'm going to stop sharing my screen, and I'm going to hand it over to Leslie. Leslie's on our, and has been from one of our initial members of the mental health PARB for Oklahoma County, and it's been a huge help. Hold on, I can't multitask. I'm one of those people that just can't do it. Okay, make a presenter, yes. All right, you can now share your screen. So,
all right.
Leslie's with the Oklahoma Department of Mental Health and Substance Abuse Services with Systems of Care. And you've been there, how long have you been there now, Leslie?
2 years.
Oh, okay.
Yes. Can everybody see it?
Yes.
Okay.
All right, well, I'm going to hand it over to you. And if you want to, I mean, besides just going over your PowerPoint, if there's anything you want to share about the mental health PARB board itself too, then that would be great.
Okay. Yeah, like Keith said, my name's Leslie Hebert. I'm a Systems of Care Senior Project Manager for Adolescent Substance Abuse and Co-occurring Disorders for the Oklahoma Department of Mental Health and Substance Abuse Services. So what I'm going to kind of do today is kind of give you guys an overview of what System of Care is and what that kind of looks like for, you know, from infants all the way up to our young adults. So it covers a wide array of services and things that we offer through the Department of Mental Health. So what is it? It's like what we like to call the umbrella of services that we offer across the state for all services in Oklahoma in regards to substance abuse, mental health, co-occurring disorders. It ranges anywhere from outpatient services, substance abuse counseling, co-occurring services for children, youth, and families in Oklahoma. It does cover, like I said, we do also have services that are specific to infant mental health as well as youth and young adults. So we also work with, you know, different sister agencies. So like we collaborate a lot with DHS, with OJA, and different other partnerships that we have within our systems of care in order to help, you know, accomplish our goals of getting kids and children and families connected to mental health services across the state. So we do occasionally we'll get calls specific from the community about kids needing care or parents just calling in general. So we do have that happen from time to time. But we also, as part of PARB, we also look at, you know, if there's mental health services that we're aware of that maybe we not necessarily oversee contract-wise, but we know that this kid might be better suited for this type of therapy, we will make that recommendation at PARB. Or if there is a service that is already being provided, we like to follow up, make sure that the kid has a psych eval and see what services that they've already been in or been offered to kind of make that recommendation. So for Oklahoma, we wanted to have access to wraparound. So what you hear, systems of care and wraparound, that's kind of, you hear them sometimes in the community interchangeably, but what we like to say is wraparound is a program within systems of care. So with that, we're going to talk a little bit more about each of these different categories. But what we noticed is once we began to bring that in our state, we saw improved outcomes. We wanted to make sure that we were creating a trauma-informed system for services across the state, that kids had access to integrated care and then provide that crisis stabilization. So one of the things that we are really push for is, you know, making sure that the family and youth have a choice and a voice in their treatment services, that it's very community-based, that we provide that cultural, you know, competent services, that we kind of, again, are inclusive of their, you know, maybe their viewpoints on certain things. So we kind of let them drive the treatment in a way. So these are just kind of what you hear in our wraparound services. So like I said, we're very family driven, like what are their goals, what are their strengths, and youth guided, this is kind of similar, you know, who are their supports, things of that nature. We work as a team. We don't, we try to incorporate what they're wanting out of treatment as well as not just dictating treatment. We collaborate with, like I said, you know, the kids in DHS custody, we invite the worker in that process of the treatment process. We focus more on their strengths and we try to build on those strengths because sometimes when you hear about mental health, it's not necessarily so much strength focused as it is deficit based a lot of times. So what we want to make sure is that we are approaching it from that standpoint and that it is individualized to that specific youth or family. So out of that, we created, like I said, we wanted to create a crisis stabilization model. So basically the purpose and goal of our youth mobile crisis system is we want to make sure we provide that rapid community-based mobile response for children and youth and young adults. So in each county, what that looks like is anybody can access it. They don't have to be enrolled in a wraparound program. So I'll share that number here in a little while. So what they do is if a kid's feeling suicidal or things of that nature, they can call this, the guardian or whoever is, noticing this within the community can call this mobile crisis and say, hey, I have this youth that, is struggling. They're having thoughts of depression. Maybe the kid's at school or something happens, or, you just see a kid in the community or your neighbor or something. So like I said, anybody can contact that, and they kind of make recommendations of how to stabilize that child within the community. And so there's the statewide access youth mobile crisis line. It's toll free. All the calls are answered 24/7 throughout the year. They're triaged according to their protocols. So like if it's a 911 emergency, they'll send that over to 911. If it's a referral for local community resources, they kind of look at that as well. And then if it's a mobile response in regards to mental health, they will, staff that as well and make sure that it gets the appropriate level of care. So the call center, the mobile crisis staff determine that level of service that's needed for each of those calls that come in. So they provide, this looks a little different now, of course, with COVID, but as things start to transition back into, I guess, if you want to call it normal again, that they were providing face-to-face 1 hour if it necessary, and then non-emergency face-to-face meeting within 24 hours. What most of our mobile crisis has evolved from, just like everything else in 2020 has evolved to using more technology. Some sites have implemented iPads that they can click a button and not have, they give these iPads to sometimes law enforcement officers where they can click a button and talk directly to, a service provider on the other end during that crisis. And so that's kind of some of the ways that we've kind of, changed around in 2020 is realize that technology can be more useful, and we can hand those to those law enforcement officers that might show up as emergency 911, but then maybe there's a mental health crisis going on. They can easily access that as well. So when we talk about who can be referred to wraparound service, is any kid, child, youth, or family who's had a serious emotional disturbance. So typically that covers a wide range of diagnosis. Are they at risk, or have they been out of home placement? So like inpatient, foster care, group homes, things of that nature, or at the potential for. Do they have, some of this history of inpatient hospitalizations where they can't stabilize, but continuously go inpatient? So that would be an ideal kid to refer to a local wraparound provider. And so what you see here is we have an online referral system, so you can actually refer that kid directly to a systems of care wraparound site, and then just making sure that you have these things below. So child, youth, young adult name, caregiver name, anything of that nature. And then also making sure, like, if you have that recommendation or that referral for this kid to services, making sure like you kind of talk with them before you just, refer them on. And so below you'll see the website for our online referral process. It systems of care, all one word, .ou.edu. And so with that, once you go to that link, you'll see a similar little brain picture that's on this slide. You'll click on that, make a referral, and it'll populate the online referral for you to make the referral. And it also has a drop down for each county and the providers for that county. So you can pick a specific provider for that county and for that kid to be referred or that family to be referred to. Like I said, it can be done by anyone. It doesn't have to be a professional that makes that referral. So this is just a little bit breakdown too of, like I said in the beginning, some of our services range from, early infanthood and child mental health services. So with this is more focused on, trauma informed in the lifespans of the continuum of care and providing that prevention and treatment of, further mental health needs, if you want to say that. So we kind of look at fostering that social and emotional well-being for infants, toddlers, preschool age children and their families. So also at our Department of Mental Health, we have specific senior project managers that are over each division. And so if you're having, you know, a kid that's struggling with early child mental health, we have a person that can kind of refer you guys to a specific provider or provide support to those providers as well when it comes to early childhood mental health. And so what that looks like, it looks different than what we would typically treat for mental health in general. So this is kind of just a breakdown of what that looks like. All these different services can be in place for that child or that family as well. So it's different. The partnerships look different. So sometimes what you see, it's, you know, is this normal development for this kid, for this child, for this family? Is there any diagnostic issues that maybe we're not aware of? Sometimes those can be challenging as well to diagnose. And then engaging those families is a lot different and sometimes more difficult. And then also making sure sometimes, like everybody that was on that previous slide is, you know, involved in that care. Sometimes, you know, evaluation brings up more issues that maybe we weren't necessarily aware of, so we take that into consideration too. So it looks a lot different. So another part of our systems of care division is that we have school-based services for different counties in Oklahoma. And so what we've noticed with this is that basically kids, 1 out of 4 students have been exposed to trauma, and how that kind of a traumatic event, which can affect, you know, their behaviors, their learning. So that's just kind of a list of things that we've noticed and we've kind of taken note of in Oklahoma in regards to, you know, our school systems and sending kids home because they're getting suspended or kicked out of class for their behaviors or things of that nature. So what we did is we worked with OSDE to create a partnership of how do we put mental health services within the schools. So these are, again, across the different problems that we kind of noticed within the classroom of why kids were continuously being sent home. This was based off of data that we received from OSDE. So then what we did is when we created these services, we created behavioral intervention services. So again, it's kind of that wraparound model is provided within the school instead of, you know, that kid might be having a difficult time, so they get a hold of this behavioral health aid that's kind of like works in partnership or sometimes embedded in the school, depending on the school and the provider's relationship, to kind of come and meet with this kid instead of, you know, sending them to the principal's office and getting them suspended or sent home for the day. So some of that is what happens within that service system. And then we also have 2 specific grants. So Project Aware and Project Aware East. So again, they work to increase the awareness of mental health issues. So they provide training within that model to school personnel to identify kids that maybe have mental health needs, and then connect them to appropriate mental health providers and services that they might need as well. And to kind of, like I said, reduce that reduction of being sent home from school. And then we have their DHS partnerships. So one of those that is real big with DHS and has been around for a while is the Mental Health Consultants Program. So this is a team of people that are based out of each region to cover, you know, they're licensed individuals in mental health and substance abuse. So they basically, the worker, if they have a kid, let's say in Oklahoma County, they'll call the that region mental health consultant and say, hey, I have this kid, I have this psych eval, I have this and this going on, and then they kind of provide that case consultation and look at, you know, really break it down and look at the recommendations maybe on the psych eval, what's going on specifically with that case. And also, you know, working with caseworkers on what's best evidence-based practice, you know, promote that education in their child and or family development. And maybe I also look at, you know, what are factors that are contributing to that specific issue or behavior that they're noticing, and then also how can they prevent the child being removed from the home or placed in further in custody. Also, you know, working with maybe even adoptions and things of that nature of like, how do we stabilize this kid and help basically bring in those supports that that kid and that family might need to be successful. And so a branch off of that was when DHS kind of approached us, Department of Mental Health, probably December in 2019, to develop what we call an enhanced foster care program. So you'll hear it a lot as EFC. And so basically what that was is DHS created a needs analysis across their system of different kids that were placed in their custody, maybe, you know, in a group home, traditional foster care, things of that nature that were on, you know, had significant mental health challenges or behavioral health challenges. And they looked at how can we best basically serve these kids. And so what they kind of looked at is, you know, looking at the children that are currently in higher levels of care, previously like settings, so needed, you know, elevated supports, wrapping them around in that wraparound provider, and also connecting them to the appropriate level of care that they need. So similar to what the mental health consultants do, but it's more specialized within their enhanced foster care program. So DHS actually identifies those kids based on an application that they receive from the worker saying, hey, I think this kid might and this family might benefit from engaging in enhanced foster care, and then from there it's sent to us. Then we also have an OJA partnership that we work closely with them to conduct mental health trainings for their local workers, for any, you know, facility workers, things of that nature. We work in conjunction with their chief psychologist in order to look at how do we improve mental health services and access to quality of mental health treatment for all juveniles in their custody at all levels, so that kid can be like at a community level with a probation officer. How do we get them connected to services to prevent them from having to go to their highest level of care? So we work a lot with them and get cases from them of how do we support these kids in custody, and also if the kid is dual custody, also kind of creating that collaboration with DHS as well. And then we have youth and young adult services that we also offer. So we have something what's called the Youth State Advisory Board. It's made of young people who have lived experience in any areas involving trauma and or experience in mental health or any other child serving system. So at Department of Mental Health, we really, like I said, you know, that's one of our founding values that we're going to base our services on. So we really want to get their input in of things that we're looking into, or like that we're looking into creating, if that is going to be friendly or accepted by youth and young adults. And then we also have specific transition to independence, which is the youth and young adults version of the track. So basically what that is if a kid is, let's say, maybe in child welfare but has no like family supports or anything of that nature, it's more geared towards that independence of, okay, how do we come around this kid and help them to develop to become independent throughout that process in that youth. We also have youth and adolescent, youth and young adult co-occurring substance abuse services. So the goal for this is to make sure that our adolescents and young adult services for co-occurring are a recovery-oriented approach to services. So it may incorporate supports within the, like any other professionals. So if the kid is, you know, has a probation officer involved, or, you know, is in DHS custody but is needing substance abuse services, we work hand in hand with those providers and those specific agencies to kind of help that process along. And then we look at make sure that all treatment provided is a trauma-informed therapeutic services to an outpatient setting that we develop skills to cope with substance abuse or dependency and co-occurring. We provide that service for youth up to age 21. And then currently in Oklahoma, we only have 2 specific inpatient facilities for adolescent substance abuse, and that is Tulsa Boys Home in Tulsa and Children's Recovery Center in Norman, and they all do their own screening process. I know Tulsa Boys Home, I believe, takes DHS kids as well, so that's something to kind of keep in mind, as does Children's Recovery Center. And then there's my contact information. I'll let you guys go ahead, and if you have any questions you'd like to ask.
You covered a lot of information quick, Leslie. Thanks for that. I want to highlight a couple of things, if I might. One is the mental health consultants, which is huge. You don't have a map. Do you have a? I think I had an old map. Do you have a map of those mental health consultants?
Yeah, it hasn't been updated yet because they're still haven't hired for Josh's position. So once that person starts, it'll probably be updated with all the contact information of those mental health.
Okay, well, I'll go ahead and send that out when I send out the other handworks and see if I can cross out Josh's name. Josh was, what's Josh's Farmer? Yeah, Josh Farmer was the director of the mental health consultants group and one of the inaugural members, along with Leslie, on the mental health PARB board, and he had a lot of really good clinical experience. So it was really interesting at those meetings to hear him talk about diagnosis and things like that. It could be a real advocate for hospitalizations and that sort of thing. So if you're looking at a case and there's clearly some mental health stuff going on, and it seems like they're on a whole bunch of medications, or they're rotating in and out of the hospital or something like that, you know, you might put in your recommendation or talk to DHS themselves, the workers, about mental health consultants on that. Other thoughts from other people? And as far as wraparound services and making a referral, so was there a list of how to make referrals on that too? On your PowerPoint?
Yeah, there's the website link at the bottom of that blue
that's
slide.
Right. That's right.
Yeah, and I have that same picture of the brain. I guess I could pull up, let me see if I still have it.
Well, and again, I'm going to email your PowerPoint out so people have it that way, along with your contact information if they have.
I'm actually going to share what it'll look like. So you'll see this screen and see how it has that little brain make a referral. You'll just click on that and it'll bring up online referral process.
Okay, great. And sorry, I've got history with systems of care. So, but you guys still looking at multi-system kids? I mean, is that still one of your priorities?
Yes.
Kids that are like IEP at school, or you know, DHS involvement, OJA involvement, stuff like that. So I know that still obviously still happens where you've got a kid that's in multiple systems.
Mm-hmm.
So those would be a good referral for wraparound, I imagine.
Mm-hmm. And even if you think that there might be some service, like the kid might qualify, what we say is typically just go ahead and make that referral anyways, because the site will make contact with that family and go through that process and even give them additional resources if they don't necessarily qualify for that.
Sure.
But they qualify for, you know, therapy or something and be able to offer that through that agency.
Good. And just so you know too, I mean, again, I've got some history, so I've got some bias to it, but I think Systems of Care has the best network of community coalitions with Jeff Talon and the Evolution Foundation. And anytime I'm trying to get do recruiting for PARB or try to get connected more with the community, I usually go attend the community team or community coalition that's associated with Systems of Care in that community. So if you are not familiar with the Systems of Care community team in your area and you want to reach out to some other folks, I've got that list too that I could send out. I might go ahead and do that. And typically they would partner with whatever coalition. So you might go, oh, I already knew about that coalition. It's the whatever coalition. I mean, they try to connect with the most active coalition in that community.
Mhm. And it's really
All
good,
right.
the coalitions too, because they'll talk about like where in services are we lacking? How can we kind of meet that need and kind of build better services across the state within those coalitions too.
Yeah, there used to be some on the referral teams would have more of an integrated kind of a community case staffing. I don't know how much of that is still done.
It's evolved a lot.
It's evolved. All right.
Yeah.
All right, I'm doing all the talking.
And most
So
of,
Joan,
I will say this, most of our sites, our community mental health centers, where maybe some of these wraparound providers might be, are going to be CCBHCs, or certified community behavioral health centers. So they will also have, some sites have like, you know, doctors on staff where they're treating both. Because what we realize is sometimes mental health and physical health have that link. You'll hear that specifically in like ACEs studies and things of that nature. And so what we've kind of looked at a couple years ago is we brought that model into our state. And so as a result of seeing good outcomes with the integrating those services, we've continued to expand that. So you'll be seeing, you'll probably hear, instead of community mental health center, you might hear CCBHC. So I want to throw that out there.
all right, so I need to update my terminology and my acronyms. Jonette, it looks like you took your microphone off. Did you have something to ask?
Yeah, the behaviors that need to be addressed in school, if the child has an IEP, it's easy. But if the child does not have an IEP, we've got to have that psych eval. And that's where we always get hung up. It takes so long to get the psych eval. I've wondered if DHS is ever considering hiring our own people to do the psych eval. In other words, to have full-time people that would perform psych evals for DHS kids.
I can speak to that because I work for the Department of Mental Health. So, but that is an interesting idea, I think. And I think that would definitely be helpful because when I worked with EOC, that was a lot of the cases, is that the kid didn't have an updated psych eval, or even we see it sometimes with PARB, like the kid maybe hadn't, you know, mental health PARB hadn't had a psych eval in the past 2 years. So that's one of the first recommendations that we make is, hey, let's get their psych eval updated and then make recommendations further if, you know, once we get that back and kind of see what's going on.
Can we possibly order or refer for a psych eval immediately when they come into custody? Because that is not usually done until months on down the line, and then we have several months wait.
Yeah, I don't work for DHS. We just partner with them, but I don't know if that's ever been discussed, or I'm sure they look into a lot of that. I know for, I've worked with them with EOC, and I know that that's one of the things that they look at, make sure that that kid has that psych eval. So I think that they're in the process of noticing that that is a huge barrier a lot of times to these kids that they're serving. So I can foresee maybe they try to change some of that in the future. But again, I don't work for DHS, so I don't want to speak for them. So.
Okay, who would I need to pose these questions to then to get DHS to answer that?
Well, we can talk to the mental health consultants that are actually DHS employees. That might be a good place to start.
Okay. Okay.
Or folks
Yeah.
on state PARB like Daniel Herring.
Yeah, as I say, a lot of times the DHS worker that contacts the mental health consultants, that's like one of the first things that they kind of look at or check for is, has this kid had a psych eval? So that's one of their first questions that they ask before they can kind of give further recommendations. So.
Well, I think that's done on paper, but in reality, I don't think all workers even think about that at the beginning of a case.
Well, it gives us an opportunity to make that recommendation.
Mhm.
Any other thoughts, questions? For Leslie or for Derek? Okay. Well, appreciate you both visiting about it, and for your ongoing partnership with the mental health PARB board out of Oklahoma County. You know, again, hoping at some point we can replicate that in other places, or at least if not a separate PARB board, at least PARB boards across the state that are paying attention to some of those same critical issues, which I know a lot of them are now. But it's really important information. I appreciate you sharing. So unless anyone has anything else, I guess we will wrap up. All right. Well, have a good rest of the week, y'all. Catch you later.
Have a good day.